Accuracy and reliability of orthodontists using CBCT assessment of adenoid hypertrophy, paper by Camila Pacheco Pereira, Nora Sofiani, Michael Major, Gison Hill, and Carlos Floresmir. Hi, I'm Camila from University of Alberta in Edmonton, Canada. The findings of this prospective study are published by the AGODO in the November edition. The objectives of this study were to evaluate the reliability of agreement between orthodontists with various degrees of cone-beam computer tomography image manipulation comfort in classifying adenoid hypertrophy. To determine how reliable these orthodontists are in screening for adenoid hypertrophy using CBCT compared with the gold standard diagnosis, the nasopharyngoscopy. This is a cross-sectional study in which a randomized list of board-certified orthodontists among a population of 34 specialists of a major Canadian city were invited to participate. The CBCT scans were not specifically taken to evaluate adenoids, but to evaluate more complex craniofacial patterns common in children with a high likelihood of obstructive sleep apnea. The participants evaluated different degrees of adenoid hypertrophy. They used the same computer and viewing software to prevent performance bias. Proper statistical analysis was used to analyze the data. 14 orthodontists evaluated 10 scans stratified and randomized by grades of nasopharyngoscopy. Inter-observer agreement, meaning between orthodontists, demonstrated no clinical relevant discrepancies showing high consistency among evaluators. However, when comparing orthodontists with the nasopharyngoscopy, the ENT diagnosis, the results demonstrated poor agreement. A kappa test was applied to evaluate the clinical determination of healthy and diseased participants. The results were also poor.
I am Carlos and we will discuss the finding of our project. An early screening should be encouraged when upper airway dysfunction is suspected. If dental practitioners could assess the nasopharyngeal area, they may be able to refer the patient for timely management by physicians. A likely reason for this substantial discrepancy in the diagnosis accuracy between this study and the previous study is how the CBCT images were reviewed. We observed that some participants frequently based their assessment only on the first sagittal view presented by the viewer software. Not all participants adjusted the contrast or moved the slide position during the evaluation, thus failing to explore the entire reconstruction or slices. So what this all means is that clinical orthodontists should exercise caution evaluating CBCT images themselves. The referral of imaging to oral maxillofacial radiologist is an option. Poor to fair diagnostic accuracy should be expected from orthodontists with average to low CBCT interpretative skills. This study draws attention to how critical the operator's subjective evaluation may be in the final diagnostic accuracy of this technology. Based on our data, we concluded that the orthodontists were making consistent and systematic errors in their evaluation process. Different levels of CBCT expertise, imaging software used, and anatomical knowledge may impact the stated screening capability. In summary, our intention on this project was to explore the screening capability of CBCT imaging to assess adenoid hypertrophy. We would like to thank all the individuals involved in this research project. Thanks for listening.